I'm Amanda Acey with Briarcliff University, and this is Substance Use Prevention in an International Setting. Today we are going to be discussing Tanzania. The first important aspect that we will be discussing is the definitions. Substance use, for the sake of this presentation, includes the use of psychoactive substances, including tobacco and alcohol, the illegal use of drugs of abuse, inhalants, and the non-medical use of prescription medications. When we talk about prevention, that means understanding how substance use has affected individuals, families, schools, communities, and countries, and then using that information and determining how it can be addressed with effective strategies, policies, and interventions. So let's discuss some global facts. We know that substance abuse affects every continent, every community, and many families worldwide. Substance abuse has been identified as the third highest risk factor for morbidity and mortality worldwide. You will never see substance abuse specifically listed as a cause of death on a list from the World Health Organization or anything like that. It's because substance abuse precipitates a cause of death like a heart attack or stopping breathing or something like that. So it can be difficult to get a proper assessment or get accurate data when it comes to morbidity and mortality directly correlated to the use of substances. Substance abuse includes the use of alcohol consumption, even though alcohol consumption is socially acceptable and legal. Globally, alcohol consumption causes 3.3 million deaths per year. Almost 11 million people inject drugs, of which 1.3 million are living with HIV, 5.5 million with hepatitis C, and 1 million with both. It is estimated that 275 million people used illicit drugs such as cannabis, amphetamines, opioids, and cocaine in 2016, which translates into an annual prevalence of illicit drug use of 5.6%. That is a most recent statistic, so that does include the legalization of cannabis in some regions. Now let's discuss prevention education. Prevention education utilizes strategies, and these aim to reduce the desire and the willingness to obtain and also to use drugs. Strategies also aim to prevent, reduce, or delay the uptake of drug use, and they can include abstinence-oriented strategies. We know here in the United States, one of the most popular abstinence-oriented strategies that's utilized in schools is the DARE program. Strategies also aim to reduce the impact of drug use and drug-related activities on individuals and communities. Education for drug abuse prevention should be seen to include both formal and informal health curricula, the creation of a safe and healthy school environment, the provision of appropriate health services and support, as well as the involvement of the family and the community in planning and delivery of programs. Prevention includes a very well-rounded group of individuals, communities, and families. Prevention reaches both youth, children as young, very young children, and adults. Now let's start talking specifically about substance use in Tanzania, Africa. So first, in Tanzania, Africa, there's an extremely low cost associated with substances. For example, It only costs $1.10 in US dollars for a half a gram of heroin. It costs 55 cents for 600 grams of marijuana. These are the comparative costs for what we would pay in US dollars to purchase these illicit substances over in Tanzania, Africa. So to put that into perspective, approximately a half of a gram of heroin in the United States right now is around $10. Injecting drug use is a growing problem in Tanzania, and it can be easy to understand that that is partially associated to the easy access and the low cost. As of 2016, Tanzania had approximately 30,000 individuals identified as those who inject drugs, and prevalence of HIV among those individuals was 35%. So it should be noted that screening for HIV among substance users is inconsistent. Also, the current year is 2020, so these statistics are coming from 4 years ago. These are also based on self-report, so these are rough estimates, and it would be safe to assume and appropriate to assume that these numbers have risen. Heroin trafficking and consumption has increased steadily over the past decade in Tanzania. One study showed that 55.9% of individuals using substances via injection also disclosed engaging in polysubstance use. Polysubstance use is simply the use of more than one substance. This is not unique to Tanzania, Africa. This is common with any individual who uses substances. 22 tons of heroin is trafficked through East Africa annually, with 2.5 tons consumed locally. So this is the 2.5 tons is not consumed specifically in Tanzania, it's consumed in Eastern Africa, but a significant amount is consumed in Tanzania, with it being part of that Eastern Africa region. And then heroin is commonly smoked with marijuana in joints called kokotili, which translates to cocktail. This is something that is not common here in the United States. So some of the high risk behaviors that are associated with substance use are common globally, and they transcend culturally. A lot of the data that comes out of Tanzania and Eastern Africa in general is related to IV and injected drug use. In Dar es Salaam, female heroin injectors are more likely to be living on the streets and have multiple sex partners. Again, this is having multiple sex partners, and homelessness is a high risk behavior and a risk factor that exists in the United States as well. Significant associations between HIV risk behaviors and heroin injection include selling items for drugs, trading sex for drugs, and being arrested. Early sexual experiences and low use of contraception. Again, all high risk behaviors that are common. This last one is a high risk behavior that is almost uniquely one that exists in Eastern Africa. It's called flash blood, and flash blood is very uncommon. It is the process of injecting oneself with another user's blood in an effort to keep withdrawal at bay. So the individual who is injecting themselves with heroin will inject themselves with the heroin. They will draw blood into the syringe in multiple times, 3 or 4 times, to make sure that the heroin is flushed out of the syringe. This is how heroin would be traditionally injected. However, when an individual is sharing that needle, when they are choosing to share their blood, then during the first time drawing their blood into the syringe, they will then remove the syringe from their body and pass it to another individual. So then that individual will then inject the blood of another person into their body in hopes that there is enough remaining heroin and levels of heroin in the other person's blood to stave off withdrawal and possibly allow them to experience a mild high. Obviously, this is extremely, extremely high risk. Historically, in Tanzania, HIV transmission was from heterosexual sex, but in the mid 2000s, heroin use, including syringe sharing and high risk behaviors that were associated with drug use, have increased the transmission of HIV. So while Tanzania was comparatively low in the continent of Africa, the HIV rate among individuals using injectable drugs was significantly higher and remains significantly higher. Again, to note, flash blood is rare and is not a common practice, but it is a practice that is almost exclusively seen in regions of Eastern Africa and has been noted to be seen in other Middle Eastern regions very sporadically. Here's some data from Tanzania. So limited studies exist, but data does exist to show high ACEs. We know that adverse childhood experiences, which is what ACEs stand for, is the Adverse Childhood Experiences study is evidence-based. We know that ACEs contribute to potential future mental and physical health, as well as the probability of engaging in high-risk behaviors. A study showed that 10% of secondary students reported household substance abuse. So low numbers are common when self-report is the mode of data collection. We know that one study indicated peer pressure was defined as a commonly cited influence for starting drug use, as well as family problem. So again, this is something that is not unique to Tanzania. This is something that exists in other parts of the globe, but this data exists in Tanzania. There is basic education lacking in the general population when it comes to substance use. One example are the risks related to needle sharing. In the United States, the risk of needle sharing is considered common knowledge, even among IV drug users, but developing nations are still in need of the education. And something that goes along with that is that knowledge alone is not enough as a prevention tool, especially when we're talking about preventing the transmission of HIV and hepatitis. You need things like clean needle exchanges and medication-assisted treatment clinics and other treatment options in order to help individuals. When we're talking about substance use prevention, you need community involvement and overall cultural norms to shift because knowledge alone is not enough. You need other things to take place. So there are international standards that exist on substance use prevention. There's a manual that was developed by the United Nations Office on Drugs and Crime and the World Health Organization. It is currently in its second edition, and it was first published in 2015. The manual discusses the general aim of substance use prevention is the healthy and safe development of children and youth, and helping them to realize their talents and potential and becoming contributing members of their community and society. The manual also explains that the most powerful vulnerability factors for individuals when it comes to substance abuse are genetic predisposition, personality traits, the presence of mental and behavioral disorders, family neglect and abuse, poor attachment to school and community, social norms and environments conducive to substance use, and growing up in marginalized and deprived communities. This manual is evidence-based and works because it is an international manual. It is meant to help guide prevention programs, the development of prevention programs. So this document describes the interventions and policies that have been found to be effective by scientific evidence in preventing substance use, and ones that could serve as the foundation of an effective health-centered national or local substance use prevention system. It also discusses how interventions and policies should exist in the context of national prevention systems, supporting and sustaining their development, implementation, monitoring, and evaluation on the basis of data and evidence. It includes drug prevention interventions and policies for infancy and early childhood, middle childhood, adolescence, and adulthood. So here are some barriers that exist in providing effective education. So there are limited existing data, especially for rural areas. Africa is a vast, vast continent. Tanzania is a beautiful and vast country, and there are many rural areas where studies have just not been done. The existing studies for Tanzania, many of them are reliant on self-report. Individuals do not always self-disclose things, especially when it comes to substance use. There are few studies in multiple forms of child maltreatment in Tanzania. The reason why this is included here, because we know that child maltreatment and how that is related to ACEs has a correlation and a direct relation to substance use. And in addition, there are limited studies in multiple forms of child maltreatment and the known consequences. The community perceptions to substance use is another factor. If adults approve of using substances, including smoking and consuming alcohol, then youth are less likely to see that as an issue and as a problem. And finally, time, cost, training, and knowledge are additional barriers to providing any type of effective prevention education. Available resources in Tanzania and some of the additional barriers. So there are some available resources in Tanzania when it comes to prevention education and treatment. However, as highlighted, there are limited specialized substance use related treatment services in mental hospitals and psychiatric units. Often, including in the United States, individuals that are struggling with substance use disorders are referred to mental hospitals and psychiatric units for care. Educational and awareness programs on substance use related consequences are available from health and welfare agencies, religious organizations, the media, and political parties in Tanzania, and there are youth community development programs. Some of the constraints to providing a lot of this stuff is limited institutional funding and just limited funding in general for any type of sustained educational or awareness programs. And community perceptions. The community does not expect success in countering substance use. So if you do not have community support and community involvement, the likelihood that a program is going to succeed will be low. Some of the strengths, however, are that in Tanzania, the communities are cohesive. There's low income inequality and strong relationships between community leaders and community members. Older generations are also against substance use. There is a lot of respect held for the older generations, and so their views, their negative views against substance use, can hold a lot of weight. Finally, any individual or group that would be interested in starting a prevention education program in Tanzania, it would be first important for them to follow best practice guidelines for international prevention education. Western prevention programs will not copy and paste in an international setting. A school-based program like the DARE program that is used in the United States would not work in Tanzania, nor would it be appropriate. Culturally, it would not translate, and those types of scenarios and situations would not work. The World Health Organization has a free guidebook and many resources available on their website. Finally, it would be important to do a local situation assessment. This is another word for doing a needs assessment. This has been developed by the United Nations Office on Drugs and Crime and the World Health Organization. Again, this is another resource that is available to anyone online. And it talks about the information that's necessary to understand the substance abuse situation in a community so that you can move forward and create some sort of prevention education program. You have to know who is using substances, what their ages, what their genders are, have a knowledge on substance abuse, understand what your community knows about substance abuse, know about the cultural values. What are the attitudes of the people towards using substances? Are there different groups that have different attitudes? What are the community and family ties look like? Do parents have time and energy to care for their children? Do people have adequate opportunities and prospects of getting a good education and training for work? Are substances easily available? There are so many questions that need to be asked and assessed in order to move on to the next step of actually creating a program. Thank you for coming to this presentation, and as our friends in Tanzania say, asante sana.